Morning, everyone. We're going to go ahead and get started. We're the Physician-Focused Payment Technical Advisory Committee, or PTAC. Good morning. Welcome to our this is our third public session. We're pleased to have all you here. In addition to members that are in the room with us, there are some watching on the live stream. Also, there'll be some folks on the phone as well. This meeting allows us to deliberate and vote on the physician-focused payment model submitted by members of the public. We'd like to thank all of you for your interest in today's meeting. In particular, we'd like to thank the stakeholders who have submitted models, especially those who are here today. Your hard work and dedication to payment reform is truly appreciated. PTAC has been very active since our last public meeting in September. Since that meeting, we have submitted recommendations and comments on 2 physician-focused payment model proposals to the Secretary of Health and Human Services that were voted on at the September meeting. In addition, we've been very busy reviewing and evaluating physician-focused payment model proposals from the public. I'm pleased to report that interest in submitting PFPM models to PTAC continues since we first began accepting proposals for review on December 1st of 2016. We've received 20 full proposals and an additional 13 letters of intent to submit proposals. These proposals represent a wide variety of specialties and practice sizes, and they propose a range of payment model types. For example, over a dozen different specialties and subspecialties are represented in the letters of intent that we've received. There is interest in physician-focused payment models by both small and large group practices. Bundled payments and care management proposals comprise the majority of the proposals to date, but we have also received proposals or letters of intent that relate to capitated payment and other payment models. We're pleased that we have so much interest from clinical stakeholders in proposing physician-focused payment models, and we're fully engaged to ensure proposals are reviewed carefully and with the needs of both clinicians and patients in mind. We are already looking ahead to the agenda for our next public meeting, which will be held here in the Great Hall of the Humphrey Building, March 26th and 27th. One simple reminder, to the extent that questions may arise as we consider your proposal, please reach out to staff through the PTAC.gov mailbox. The staff will work with me as chair and with Elizabeth, the vice chair, to answer your questions. We have established this process in the interest of consistency in responding to submitters and members of the public, and appreciate everyone cooperating with us. Today, we will be deliberating on 4 proposals and deliberate on 3 proposals tomorrow. To remind the audience, the order of activities for each proposal is as follows. First, PTAC members will make disclosures of potential conflicts of interest and announcements of any committee members not voting on a particular proposal. Second, discussions of each proposal would begin with presentation from the preliminary review team, or PRTs. Following the PRT's presentation and some initial questions from PTAC members, the committee looks forward to hearing comments from the proposal submitters and the public. The committee will then deliberate on the proposal. As deliberations conclude, I will ask the committee whether they are ready to vote on the proposal. If the committee is ready to vote, each committee member will vote electronically on whether the proposal meets each of the Secretary's 10 criteria. Those of you who have read all the PRT reports ahead know that members of the committee have used the term "not applicable" to refer to the elements of proposals that they believe the criteria are not applicable to. We will discuss this more in the context of individual proposals, and we look forward to input from the public on this particular issue as we finalize our policy. The last vote will be on an overall recommendation to the Secretary of Health and Human Services. And finally, I will ask PTAC members to provide any specific guidance to ASPE staff on key comments they would like to include in the report to the Secretary. A few reminders as we begin discussions on the first proposal. The PRT reports are reports from 3 PTAC members to the full PTAC and do not represent the consensus or position of the PTAC. The PRT reports are not binding. The full PTAC may reach different conclusions from that contained in the PRT report. Finally, the PRT report is not a final report to the Secretary of Health and Human Services. PTAC will write a new report that reflects the deliberations and decisions of the full PTAC, which will then be sent to the Secretary. It is our job to provide the best possible recommendation to the Secretary, and I have every expectation that our discussions over the next few days will accomplish this goal. I would like to take the opportunity to thank my colleagues, all of whom give countless hours to the careful and expert review of the proposals before them. And thank you again for your work, and thank you to the public for participating in today's meeting in person via live stream or by teleconference. So before we get started, I'd like to turn to my Vice Chair, Elizabeth Mitchell, for any comments you'd like to make.
Thank you, Jeff. And I would just like to add my thanks to the committee members who have, as you have said, have really contributed countless hours to this process, and to the submitters for bringing such good ideas forward. I think we are achieving our aim as set out in MACRA to create a transparent and open process for consideration of new ideas to expand the Medicare payment portfolio. And just want to thank you all for your commitment.
Thank you, Elizabeth. The first proposal we will discuss today was submitted by Renal Physicians Association, or RPA, and is entitled Incident ESRD, or End-Stage Renal Disease, Clinical Episode Payment Model. PTAC members, as we start the process, let's start by introducing ourselves and at the same time read your disclosure statements on this proposal. So I'll start with myself. I'm Dr. Jeffrey Baylett. I am currently the Executive Vice President of Healthcare Quality and Affordability with Blue Shield of California. On the first proposal, I have nothing to disclose. We can go ahead and start with Tim.
Tim Ferriss. I'm the CEO of the Mass General Physicians Organization, and I have nothing to disclose.
Grace Terrell, CEO of Envision Genomics, and I have nothing to disclose.
Harold Miller, I'm the CEO of the Center for Healthcare Quality and Payment Reform. I gave a presentation on alternative payment models to the Renal Physicians Association annual meeting in March 2016, and I was compensated for my time and travel. During that presentation, I described potential approaches to APMs for patients with chronic kidney disease. While there, I met with a group of RPA leaders to answer questions about APMs, and I provided comments on a very preliminary concept paper they had developed about bundled payments for chronic kidney disease. But I have had no further involvement with RPA or its members in the past 12 months, and I have not had any involvement in the preparation of the PFPM described in the proposal. The proposed payment model would have no special or distinct effect on me.
Paul Casal, cardiologist and executive director of New York Quality Care, the ACO of New York Presbyterian, Weill Cornell, and Columbia. I have no disclosures.
I'm Bruce Steinwald. I have a little consulting practice here in Washington, D.C., and I'm doing some work on payment policy with the Brookings Institution, and I have nothing to disclose on this proposal.
Elizabeth Mitchell, President and CEO of the Network for Regional Healthcare Improvement, and I have nothing to disclose.
Lynn Nichols, I direct the Center for Health Policy Research and Ethics at George Mason University, and I have nothing to disclose.
Kavita Patel, an internist at Johns Hopkins and a fellow at the Brookings Institution, and I have nothing to disclose.
I'm Bob Berenson. I'm an Institute Fellow at the Urban Institute, and I have nothing to disclose.
Rhonda Meadows, Executive Vice President, Population Health, Providence St. Joseph Health. I have nothing to disclose.
Could we go ahead and ask the staff to introduce themselves? Mary Ellen?
I'm Mary Ellen Stallman, and I'm the ASPE staff lead for PTAC.
I'm Ann Page. I'm the designated federal officer for the PTAC committee, which is a committee governed by the provisions of the Federal Advisory Committee Act, FACA.
I'm Adele Schartzer. I'm a contractor. I work for the Urban Institute, and I'm helping staff this particular committee.
Great, thanks everyone. I'd like to now turn the microphone over to Dr. Paul Casal, who led the preliminary review team for the first proposal. Paul?
Thanks, Jeff. Look for the first slide. Great. Thank you. So, yeah, the title of this proposal is Incident ESRD Clinical Episode Payment Model, submitted by Renal Physicians Association, and I'll likely refer to it as the RPA proposal because it seems easier to say. So, which way do I point this? Okay. So on, in my presentation, I'll briefly review the composition and role of the PRT, then to give an overview of the proposal, summary of our PRT review, and then evaluation using the criteria, and finally key issues identified. Jeff has already gone over this in terms of PRT. Just as a reminder, PRT report is not binding on the PTAC, and PTAC may reach a different conclusion from that contained in the PRT report. Where am I supposed to point this out? Let's try this one. Okay.
Just testing you, Paul.
Okay.
Okay.
Yeah. Yeah. Okay, so model overview. The model focuses on optimal transition to dialysis. Some modalities, as an example, initiating dialysis with catheters are associated with higher costs, higher rates of infection and hospitalizations. Advanced preparation is required for less costly modalities. So the eligible population for this proposal are patients with incident ESRD who are enrolled in Medicare when they begin dialysis. The episode length is 6 months, beginning the first day of the month during which dialysis begins, unless it begins after the 16th of the month. And the major components are a shared savings loss based on total cost of care during the episode, and also depends on performance on quality metrics. And then a second component is a transplant bonus of $3,000 if that occurs prior to beginning dialysis, or $1,500 during the episode. At the end of the presentation, there is a slide that provides much more detail around the specifics. I know everyone's read the proposal, so I'm just leaving it at the back of the proposal for reference, rather than going through the specific details around all of the payment. I'm sure we'll have discussion around that. Okay. So summarizing the PRT criteria, you can see here, and then we'll walk through each one of these individually. So criterion 1 for scope, the PRT conclusion was proposal meets the criterion. On the strengths, this APM is the only one that currently focuses on high-cost ERCD patients. The comprehensive ERCD care, or CEC model, has limited participation of approximately 10% of nephrologists. So this model expands access to APMs to more nephrologists and their patients. And one of the ways it expands is that this model does not include the requirement for minimum number of cases or patients or other geographic considerations that make participation in the CEC model difficult for many nephrologists. One of the concerns we discussed in the PRT was the potential issue of random variation in spending for savings and loss calculations, particularly for small nephrology practices, given the fact that ESRD patients tend to be very high cost. Oh, I went too fast. Jeez. Okay. Criterion 2 on quality and cost. The PRT conclusion was the proposal meets the criterion. The strengths that we identified was that the model addresses the high annual spending for incident ESRD patients, including potentially preventable hospitalizations related in part to suboptimal transition to dialysis. And the model makes shared savings payments contingent on a number of important quality measures. The concerns as outlined and discussed by PRT, the biggest opportunities for improvement need to occur prior to dialysis, but the episode begins at dialysis initiation. So the PRT is concerned about the ability of nephrologists to influence upstream care given treatment patterns. The minimum quality score for shared savings is 30, which is achievable merely by reporting performance. The PRT would like to see greater emphasis on patient experiences in the quality score threshold. And finally, the difficulty we identified in evaluating the impact of transplant bonus on quality and cost. For Criterion 3 payment methodology, the PRT conclusion was that the proposal meets the criterion except for the transplant bonus. So the strength was that the model is designed to direct higher payments to nephrologists who achieve better results for patients in the first 6 months of dialysis. Again, this is a time of particularly high costs and poor outcomes. The concerns is that the methodology does not include upfront payments to providers to support enhanced education and care management. The shared savings payments are based on risk-adjusted spending and regional benchmarks, but again, small numbers could impact the effectiveness of the risk adjustment. Again, weighting of the quality measures we feel should place more emphasis on patient experience. And then the kidney transplant bonus is an area of major concern, as it is unlikely to change the net number of kidney transplants due to the organ supply constraints. And factors determining transplant are largely out of a nephrologist's control. Encouraging transplant referral and education could more accurately reflect nephrologists' actions. For Criterion 4, value over volume, the PRT conclusion was that the proposal meets the criterion. The strength identified was the model provides incentives to reduce the total cost of care for incident dialysis patients, in part by reducing the rate of hospitalizations and other avoidable complications of treatment. The concern that by beginning the episode with a procedure, this model could create an incentive to start dialysis earlier in the disease process when patients are healthier and less likely to have complications. For Criterion 5, flexibility, the PRT conclusion proposal meets the criterion. The strength that we identified, the model provides greater flexibility than fee-for-service, Medicare, or the CEC model in the types of activities physicians could undertake to deliver high-quality health care, and providers could then use the shared savings payments to support a range of activities to improve quality. The concern that the model requires providers to make upfront investments that they hope to recoup during the reconciliation. This could discourage practices, particularly small practices, from making expensive but valuable investments. The ability to be evaluated, the PRT conclusion proposal meets the criteria. Under strains, the PRT believed it is feasible to assess changes in spending and quality associated with model implementation. The goals of the model, the quality measures, and potential impact on healthcare costs are clear and can be evaluated. The concerns, again, for assessment of quality outcomes, there may be challenges in reporting some of the quality measures through the EHR, particularly the patient experience measures, if a nephrologist does not participate in the RPA-sponsored Kidney Quality Improvement Registry. Under Criterion 7, integration and care coordination, PRT conclusion proposal does not meet the criteria. The strengths identified, the model would indirectly encourage nephrologists to establish better mechanisms for communication with other providers in the community regarding patients with CKD who are likely to need dialysis in the future. And the model would also implicitly encourage nephrologists to improve care coordination with the patient's other physicians. The concern, however, is that the proposal does not provide clarity about how providers would achieve better coordination both prior to and during dialysis. There's no indication as to whether or how nephrologists would involve other physicians in the APM entity or share savings and losses with other providers. Under Criterion 8, patient choice, PRT conclusion was that the proposal meets the criterion. The The strengths identified was this proposal has the potential to expand the range of treatment options available to patients with incident ESRD by encouraging early education and preparation for the transition to dialysis. The proposal also could encourage providers to identify patients unlikely to benefit from dialysis and educate patients about the alternative of conservative management of their CKD. The concern is that the model may incentivize providers to start dialysis earlier in the disease process when patients are healthier. And the transplant bonus may encourage patient choice by providing a pathway to overcome existing barriers, but the large size of bonus may influence the role of patient preferences. Under patient safety, the PRT concluded proposal meets the criterion. The strength identified was this proposal has a clear focus on avoiding hospitalizations, reducing infection rates, et cetera, for patients during the first 6 months of dialysis. And for criteria 10, health information technology, PRT conclusion was proposal meets the criterion. The strengths, all providers would be required to use CERT. Oh, yeah. Nephrologists and other participating providers would be encouraged to coordinate care prior to and during dialysis with the aid of health information technology. The proposal notes that the RPA Qualified Clinical Data Registry would be available to model participants and would facilitate the collection of patient and disease data. The concern was this proposal does not provide specific information about how to encourage use of health information technology specifically. So key issues identified by the PRT. The PRT supports the proposal's goal of improving the transition to dialysis for patients with incident ESRD. The PRT's major concerns are, one, the upstream activities. The model has potential to improve quality and reduce costs, but it relies on the assumption that the same nephrologist or nephrology practice is involved in the care of the patient for an extended time prior to and then after dialysis initiation. In terms of upfront investments, the model's payment methodology requires upfront investments from providers for patient education, care management, and other services that could be returned to providers during reconciliation. However, small providers are particularly vulnerable to random variation that could put that investment at risk. And the third concern relates to the transplant bonus. The PRT supports efforts to increase transplantation, but paying bonuses in this model is problematic and an unnecessary component of the model. So with that, I'll stop and ask my fellow PRT members if they have additional comments before opening it up. So, well, Harold and then Jeff.
Go ahead.
None.
Thanks.
Okay.
I have no specific comments to make, Paul, but I think if there are clarifying questions, this would be a good time. Bob.
Yeah, I just want to talk a little bit about the eligibility criteria here. As I understand it, it's people who are already on Medicare, not populations who will become eligible by virtue of having ESRD. Isn't that a relatively small percentage of a renal physician's dialysis population, and isn't it a pretty unique population? I guess, so one, do I have that correct, that it's a minority of dialysis patients? And I'll ask them too, but did you explore that at all?
Yeah, it's our understanding that it's patients who are on Medicare.
So that's, I mean, most people who, my understanding is that, and there's some data here which I don't understand, is that most ESRD patients are below 65 and become eligible because they start dialysis. They are not already on Medicare. So we are dealing with a subpopulation of patients who are in a renal physician's practice here. And so one, I think that exacerbates the problem of small numbers, but two is, would we expect behavior change for just a relatively small percentage of a physician's practice? Dialysis practice is my question.
It's not as small as you're representing it to be, and I think we should ask them that. So anybody who would have chronic kidney disease when they become eligible for Medicare and go on Medicare and who then progress to end-stage renal disease would be included in this. The population you're talking about would be people who were commercially insured or commercially insured, who would then reach end-stage renal disease, and then there's a 20-month period whenever they don't become eligible for Medicare anyway. So that population, the commercially insured going on dialysis, wouldn't be included.
Or the Medicaid insured or the uninsured.
But anybody who goes on Medicare and has chronic kidney disease when they go on Medicare, or develops it afterwards presumably, and then progresses to end-stage renal disease, would be included in this population. And I'm not sure that we ever tabulated that specifically. My recollection is that that's, I don't know, a third to a half of the people, but we can ask them that.
Okay. All right, thanks.
Tim?
So I have a question for the whole PRT that this proposal raises, but it's come up in other proposals. And the reason why I'm pointing it out is because we appear to be inconsistent in our recommendations about this. And so probably we're learning as we go. But the concern raised on Criterion 3, the methodology does not include upfront payments. We've actually stated the opposite concern in the past as well, which is if the payment is upfront, then and that's at risk, then you have a possibility for the practical problems associated with clawbacks and the associated practical problems. So both upfront payments and after the fact payments present challenges. Right. We've stated it here as a concern, but I would say that I'm not sure that we have come to some. And I'm not sure maybe the economists in the group can help us out here. But I don't know that there's a preferred way. It may be that both ways have positives and negatives, and that the context might be important.
Right. Len, you want to comment on that?
Well, just as the before-named economist in the room, I would say both God and devil live in the details, and so it really does depend. You can do it smartly either way, and I would say our task is to decide, A, if what they proposed meets the standards we worry about, and B, if there are modifications we would like to suggest, and I think that'll come out. But to me, the big thing about the PRT's conclusion here was that they were afraid the investment upstream wouldn't take place without some kind of money, because they have to do that on spec in essence, and that's different. You could have a partial upfront and then an ex post that would solve your nuance problem. Don't worry, there's a solution.
It'll work itself out.
Well, I just want to add one thing. I think in our PRT discussion, one of the strengths of this, because we were comparing it a bit to the CEC model, and one of the strengths was this would involve, the smaller groups in areas where there is no CEC model available to them. And so I think part of our thinking around that was, as you involve these smaller practices, potentially more rural, et cetera, the need for some upfront investment is going to be important.
Can I just add to Tim's point, because I think that is a general issue going on. There's also a difference between whether the upfront payment is an incentive payment that's being given somehow then to be taken back if the practice doesn't achieve something, versus a payment that's designed to cover a cost. And I think on one of the other proposals, the issue was it's an incentive payment. It's not intended to cover a cost, and then it's being taken back if the practice doesn't achieve it. The issue here was, the concern was, if the practice needs to incur new costs and doesn't have any upfront way to pay for that and is dependent on getting a shared savings payment, which it doesn't know whether or when it will get, that could be biased against very small practices that don't have those resources. So that was the distinction.
Bruce.
It's my understanding that ESRD patients and Medicare beneficiaries are major consumers of Part B drugs, particularly Epogen for the relief of anemia related to kidney failure. And I didn't, here's the standard disclaimer, I didn't see it in the materials I read, but the disclaimer is, it could have been there and I missed it. And that could apply to almost any of the proposals, I'll just say. So I won't repeat that disclaimer. But was there some discussion either in the proposal or your discussions with the proposer or amongst yourselves about how this model would affect the consumption of Part B drugs? And is that one of the targeted areas of potential savings under the model?
It's interesting. I don't think we had that discussion in the PRT that I can recall, in particular, as whether it be impacted.
The drugs you're referring to, Bruce, are bundled into the dialysis payment now. So if patients on...
Not Epogen, I don't think so, or iron, or some of the drugs are, but others are not.
Well, the submitters are going to clarify that for us. I'm seeing a lot of heads nodding over there, so we'll get clarification on that point. Kavita?
All right, I have it's not really for the, actually it is for the PRT, but it might be for staff too. I'm just struggling, I'm kind of building off of Bob's analytic question, and in table 1A on page, I don't know what, it looks like, if I'm reading this correctly, that there are a total of 51,240 patients who got the Medicare benefit and had some Medicare benefit that are kind of potentially in this denominator for this payment model. And then of that, 31,000, so a little over half, got it because of age. And it looks like only 700 were in because of end-stage renal disease. So I'm just trying to understand the actual population of people, kind of just building on Bob's question of if this really is like people who are kind of imminently going to be on dialysis and would not have already had been on Medicare potentially, or I'm just trying to ask what the denominator is. And then the second question, somewhere in the conversation, one of the criticisms that you pointed out, Paul, was this inability to kind of think about going upstream, the coordination and going upstream. And in the back and forth with the clinical expert from Penn, they talked about that need. And then in response, RPA, I thought, provided a thoughtful kind of assessment of, yes, we agree, but unfortunately, by the time they come to us, it's so heterogeneous, we can't really get to the upstream. I'm just curious if you all could put a little more color onto that potential to go more upstream into like the stage 3 and 4 CKD, and I think you went into some of that.
Yeah, I'll take the second one first so we can think through the numbers again.
Yeah.
We had a lot of discussion around that and with our expert from Penn and with the submitters because, and I think it may, it depends a little if you're at an academic medical center versus in the community, I would say a bit, where the experience of our expert at Penn was, well, they check in with me once a year. They're sort of managed, they have CKD that's advanced. They check in with me once a year, but they're really managed in their local community. And then they may then get started on dialysis. They may be involved, Penn they may start their dialysis, but then ultimately they're going to be cared for locally because they're not going to be commuting back and forth for their dialysis. And so we did have concerns around that. So who's going to be responsible for that upfront education in terms of even for transplant evaluation and then, preparation, putting the graft in, et cetera, and all of that. And so I think there is a bit of difference depending on the experience at the academic versus the community, although I think we recognize as one of the concerns is that a lot of these patients, in the current system, may not be seen by any nephrologist till they start dialysis, and we talked about that. So they're trying to get upstream on that, and so that's going to require more care coordination, et cetera.
And part of a lot of the expense in the first 6 months is chewed up for people who go to dialysis because they have a catheter in place, so the infection rates, et cetera. Ideally, either they're going to get a transplant before they need dialysis, or they can get a shunt, which would be the ideal way, or peritoneal dialysis. And the challenge is that if it's a vascular shunt that needs to be placed, those have to mature, and they're, we talk with our expert and the nephrology submitters, and that takes months for that to mature. So it's a timing issue, and we also talked about, well, where's the marker? Because again, we're trying, ideally, more care that can be delivered up front prior to dialysis instead of having people crash into dialysis. That's really going to get at the cost, the hospitalizations and some of the complications and mortality that they talked about. There's a significant mortality increase if you go into dialysis on a catheter. The challenge is there's no specific marker. They talked about glomerular filtration rate and some of the other labs that get you into the different stages, but there's not a consistent belief. There was some flexibility on interpreting when is the appropriate time. So there's a lot of moving parts, I guess, is what I'm trying to say. We pressed hard on, couldn't we just put a, if your glomerular filtration rate is X or your kidney function is Y, we're going to put a graft in at that time that gives us 18 months of upstream, and then we can start to impact some of the complications. The other point is that the statistics show that 28% of end-stage renal patients have not seen a nephrologist prior to starting dialysis, and another 43% see a nephrologist less than 6 months. So you're talking about 71% of the patients who end up on dialysis really had almost, had limited or no nephrology care, and that's where that upstream input would be necessary. So hopefully the submitters, when we get them up here, we can talk about that as well. Elizabeth, you had a, right? Or Paul, wait.
The numbers question.
Sure. I wasn't sure exactly what your question was. Right. Table 1A was our effort to try to determine how long people had been on Medicare people who were on Medicare when they started dialysis. The moment that they started dialysis, how long had they been on Medicare? And the answer is a long time, more than a year. It wasn't that they just suddenly became eligible for Medicare and then suddenly started on dialysis. There are a lot of people who are on Medicare getting dialysis that didn't start dialysis on Medicare because they were still covered by commercial insurance or whatever. In fact, it's one of the odd things about this structure is that, in a sense, Medicare is getting them after somebody else has been responsible for start. It's not a very small proportion, but if you look at all the people who are on ESRD, Medicare is, if you will, taking care of them after somebody else was responsible for paying for the start. So this is focused on the people that, under Medicare at least, there is the potential to be able to do something when they start. You could potentially then extend this to other payers. You could say some commercial payer could have the exact same model, because they would say, we're paying for these patients for the first 20 months, and that's a time whenever, based on all this data, suggests that there is a very significant opportunity to be able to reduce costs, et cetera, so it would certainly be attractive to them also, but we're only doing Medicare right here. So this particular area of disease has a really fascinating margins between, when commercial insurance, et cetera. And so also anybody here who would be uninsured and who would be starting home dialysis would be starting under Medicare initially, but that's a fairly small population.
Kavita, if you flip back to table C.3, it shows the health insurance coverage status of incident ESRD patients, and it looks like about 60% have Medicare when they're incident. Sorry, I know there are a lot of tables, but.
Okay. All right, very good. Elizabeth.
Thank you. My question is around the quality metrics, and this might be better for the submitters, but particularly around the patient-centeredness and the promise metric and the referral to transplant. Were there any concerns about sort of collection of the information, particularly if it's across providers? And any thought about what is an optimal outcome given the various scenarios for treatment, and also what interaction you might have had about having a threshold beyond just reporting to actual performance?
Well, I think a lot of our discussion focused on the weighting of it, that being the concern that it wasn't, there were a lot of measures, and the experienced ones we felt should be weighted higher. In terms of the collection, I think we identified the one around their QCD, around their registry, and if you're not participating, particularly if you're trying to reach out to smaller groups and rural, et cetera, that may or may not be part of the registry. I don't recall we had much, in terms of the outcome versus the reporting. I'm not sure we discussed that extensively. I think a lot of the emphasis was around the weighting of experience versus all the process measures. That would be important to weight those higher in terms of qualifying for the shared savings.
I think the issue with this population, this model, is that patients who are on dialysis are known to have problems in terms of complications and hospitalizations, et cetera. And so in a sense, the whole thrust of this is about reducing that and thereby improving it. So in a sense, the quality improvement is really fundamentally focused around that idea of helping patients during that initial period of dialysis to not have complications end up in the hospital, to be able to get a fistula rather than a catheter, not be subject to infections, et cetera. So in a sense, there's sort of, this is really, the payment model is fundamentally directed at a particular quality initiative. It's not saying we're going to somehow pay you more and we hope that you're doing it in the right way, or that you're spending less and we hope because if they're on dialysis, I mean, roughly about almost a half of the cost of during that period of time is the dialysis itself, and most of the rest ends up being these avoidable hospitalizations. So that's kind of why we thought it was important to make sure that the patient experience, et cetera, was being weighted appropriately, but it wasn't that somehow you were being rewarded for a mysterious quality improvement. Fundamentally, if you're going to save money, it's probably because you've achieved the quality improvement that this is about.
Although I would add, in terms of the experience part, not, certainly not going to the hospital, not being in the ER, that's all very good. But even our expert at Penn, when they come in with their CKD and he mentions dialysis, I mean, that's a big, the people don't want to hear that. And so the experience that people have around the conversations and the education and as they move from CKD to dialysis is important, to be able to measure and understand what that experience is. And I think that's part of what you're, trying to get at in terms of how are patients. And again, we highlighted that a little bit in terms of, could there potentially be an unintended consequence of people moving to dialysis sooner than not based on this model. So, so I think the registry is helpful in terms of the reporting, but not everyone necessarily will have access to that potentially. And how would you measure it?
Grace?
It's interesting to me that a lot of our conversation here is not around the doesn't meet criteria. One that criteria 7 about integration and care coordination. And so this is something that may be a comment now. It may be something that our presenters want to clarify, but I think it's a broader issue as it relates to how you all may have analyzed that. And this has to do with some known facts about quality of care at this point in somebody's journey into end-stage renal disease. Specifically, one thing that I believe is well known, you sort of alluded to it, Jeff, is vascular access and how that's performed in the community makes a great deal of difference. So if you've got a shunt placed by a vascular surgeon who does hundreds of these, then your outcome is better than somebody who does it occasionally. So that to me looks like an opportunity to have talked in great detail about the care coordination and integration, but the response that they had back was, well, we wanted to make it so it would be relevant and sort of at the local level as it relates to there may be small rural communities or whatever where this, where innovation or care coordination would have a different tone or color than it would somebody else. So this is a big issue with respect to the U.S. and what constitutes a standard of care and what constitutes a standard of quality as it relates to people coming to us wanting to think and talk about care coordination and integration, because it's not equal everywhere in the U.S. But we do know that there are some very different outcomes that occur as the result of some communities having access to things. I'm an internist at Wake Forest Baptist Health, and one of the debates that has happened there, and I believe been resolved, is they have many, many good vascular surgeons. They all like to do these shunts. They're going to have one guy do it because he does the best, and the access is, the outcomes are better. That's a true, quality outcome in a place that happens to have a lot of resource. That's not going to work so well in a rural area if there's one vascular surgeon within 200 miles or something. But yet the payment is supposed to be the same across the country. So their response to this was actually not a bad one, which is we need to give it some flexibility across the country for rural communities, small communities, as well as large ones. But that's kind of a big deal with respect to anybody's individual outcome. So I would like to hear how far the committee actually pushed on this issue of integration, care coordination, and then when the nephrologists have a chance to speak, I would really like to get their thought process in a little more detail about why they left it so vague, because the PRT said didn't meet criteria. But this is an issue that actually I think is a much bigger one, not only for this proposal, but for many. And it just has to do with how are we going to evaluate things when we know that some types of behaviors in some situations are going to be better than others.
Yeah, I think we had a fair amount of discussion around this issue of care coordination integration. We talked a bit about the vascular access, but I think it was even more around what I mentioned before around patients with CKD who sort of have this every 6 months or yearly visit with a nephrologist somewhere, but then they're sort of managed locally, and it's not until they then go on dialysis and then who's actually managing their care and who's making the decisions about when they're going to put the graft in, et cetera, when there may be sort of the expert nephrologists who they have little contact with, and how are you going to specifically do that coordination with either the local internist in particular. But, I think what you've said about vascular surgeons applies to many others, right, where certainly volume of procedures and outcomes certainly have a significant relationship. But so I think, and you, Jeff, if you want to add to that, but I think we had a fair amount of discussion around the concerns around integration and care coordination.
I think the other point, Grace, was that in many instances, patients with chronic kidney disease they'll travel a distance to see the nephrologist on these check-in appointments that Paul's alluding to, but when they get their dialysis, which is on a serial basis, they tend to get that closer to home. So that was another challenge. So in some centers and situations, the nephrologist that's treating them for the end-stage renal disease is also the nephrologist that was supporting them, but not always the case. So again, one of the reasons that it didn't meet was it was underdeveloped relative to talking about how this model is actually going to drive that integration. So it's not necessarily it wasn't there or isn't happening. It just this model specifically didn't address it with a granular detail that we felt sufficient for it to meet the criteria. Is that I'm just looking at my colleagues. Harold?
I would just add, for me, this comes down to the issue we were talking about with Tim before was, is the payment model designed in such a way that would actually support what you think people would want to do? It's not necessarily that to be specified that, but there's actually lots of care coordination issues here. There's how do you reach out to the PCP for people who are headed in this direction? How do you talk to the vascular surgeon? How do you deal with other specialists who the patient may have comorbidities that need to be managed to keep them out of the hospital? Because it's a total cost. So they could be being hospitalized not just for complications of their dialysis, but for access, but for other kinds of conditions that they have. So the issue was, in theory, the nephrologist is going to have to be managing all those things, and it's just a shared savings model. So the question was, well, is that really going to enable all that to happen? That was, and we said, it wasn't that we wanted to specify it, but we didn't see it articulated as to how one would imagine that working well and whether it would work well under this particular payment model.
Thank you, Harold. And Bob, we're going to get to you, and then we'll invite the proposers to come to the table.
And this, again, I'll be asking the docs, but I just wanted to know if the PRTs had any insight into this. The proposal had a lot of information about very high mortality rates early on. There was a discussion about both going upstream to predict and prepare for dialysis and also crashing into dialysis. I'm just wondering if there's two populations here, one that are going into the hospital in the ICU for some other reason and get acute renal failure. Dialysis has started, and many of them don't survive. So the technical question is, does the episode start with outpatient dialysis for survivors of the hospital or for any dialysis? So that's my concern, is that we may have two populations, and I'm just wondering who this payment model applies to, if you know what I'm asking.
Yeah, and Harold was just whispering to me, reminding me that acute kidney injury, I believe, was excluded. So it would not apply to that scenario that you just suggested.
Does it start with an outpatient dialysis or any dialysis? It doesn't. It's not specified.
Yeah, I think it can be inpatient or outpatient.
Yeah,
but not
both.
acute.
No, I think it's outpatient. It's outpatient. But the issue is they're not starting it because of an acute injury that occurred in the hospital. They have to be starting, they may have started in the hospital, but first dialysis, but it has to be because of chronic kidney disease, not because of something that happened during a hospitalization. For
so the question I'll be about to ask is whether that high mortality rate and presumably in the discussions you had with them, high cost in the first couple of months applies to that population that's not the acute kidney injury, and that's what I'm interested in.
Okay. Thank you, Bob. So we're going to go ahead and invite the submitters to come on up. I think you've got to flip your 10 table there, flip them over. We have 10 minutes, and then the committee will engage in questions. Appreciate it. And thank you all for coming out. We appreciate that. So if you could introduce yourselves and...
Great, I'll start. My name is Jeff Gillian. I'm a nephrologist from Denver.
I'm Dale Singer. I'm RPA's Executive Director.
I'm Robert Kenny. I'm a nephrologist from Baton Rouge, Louisiana.
Terry Ketchersid, a nephrologist from Southern Virginia.
Michael Shapiro, nephrologist, San Diego area, and president of the RPA.
Thank you.
Well,
Please.
Thank you all very much for allowing us to come. As I mentioned, my name is Jeff Gillian. I'm a nephrologist from Denver, and certainly on behalf of my colleagues here, we want to thank this committee for inviting the Renal Physicians Association to discuss the physician-focused payment model for patients in the incident period of end-stage renal disease. As you guys have already come to conclude, end-stage renal disease affects nearly 500,000 patients and accounts for 7% of all Medicare spending. And each year, over 120,000 new patients start dialysis, of which approximately 50% by our estimate are Medicare-eligible patients. And this time frame of incident dialysis accounts for a disproportionate share of those overall costs. And since 1973, really, this group, the RPA, has represented nephrologists in the pursuit and delivery of quality renal health care and has been the leading advocacy organization for the renal community. And in this endeavor, the RPA represents the voice of practicing nephrologists in the United States, and we remain quite committed to public policy which supports patient-centered quality outcomes, clinical safety, and responsible resource utilization. So this morning, we look forward to reviewing our clinical episode payment care model with you and answering the questions, many of which have already come up this morning, and we're looking forward to discussing those with you. I want to start, though, by saying that throughout the design of this model, we have really maintained intentional focus on 5 key tenets. And I just want to share those with you so that we kind of level set. The first key tenet is physician flexibility, which we just discussed. And we wanted to use that to better ensure care coordination, which I will go into in more detail, along with patient education and shared decision-making. The second was to incentivize optimal transition to end-stage kidney disease and ultimately into the prevalent dialysis time period for distinct patient populations. And that includes, as we mentioned previously, those that had prior nephrology care and those that had limited or no prior nephrology care. The third tenet was to reduce the very high spike in cost associated with the care of these populations. The fourth was to increase patient-shared decision-making regarding options for renal replacement therapy, and very specifically for alternatives, including conservative medical management and renal transplant. And the final tenet was to reduce and even eliminate unintended consequences that might undermine the clinical and cost savings benefits of any new payment model. So as we discuss this payment model, I want to kind of remind the members of this committee of really the magnitude of this issue. Based on published data, and in spite of clear medical benefits, nearly 80% of patients begin dialysis suboptimally, which might include initiation with a central venous catheter in place, without shared decision-making, and/or without the benefit of essential care coordination. And this places undue clinical and financial costs both on the system and also on patients in those first few months of dialysis, and often leads to longer-term health-related issues. And as noted by your committee's own analysis, the cost of dialysis in the first few months is quite expensive and may even reach $90,000, with the direct nephrologist billing accounting only for a very, very small amount of that total. Hospitalization rates, readmission rates during this time period tend to be very, very high, and that's related in great extent to, as I mentioned, that suboptimal transition, inadequate patient-shared decision-making, and limited care coordination. And so as we constructed this alternative payment model, we identified several opportunities within the current reimbursement environment which may contribute to the high costs and unsatisfactory clinical outcomes which I just described. And some of these include providing non-dialysis options for patients whose quality and longevity of life might not be well served by receiving dialysis, enhancing alignment on reimbursement across the entire continuum of care, and enhanced payment structure aimed at reducing hospitalizations, provision of greater patient choice, and understanding of home dialysis options, which we think may mitigate some of those issues you discussed with regard to vascular access. Waivers to allow mechanisms that will improve care coordination, patient transportation, and other obstacles across to improve healthcare access, and ultimately greater advocacy for and access to renal transplantation. The RPA believes that a novel payment model, which includes costs for patients across this care continuum, will positively impact patient experience, care coordination, clinical outcomes, and resource utilization during this time period. And ultimately, that benefit will impact the prevalent dialysis time frame as well. And so with these points in mind, the RPA based this proposal on a shared savings model with requirements to achieve well-vetted, evidence-based clinical metrics and patient-centered outcomes. And these metrics, which we've begun talking about already this morning, were chosen to represent really tangible results to impact those clinical outcomes and reduce complications, decrease hospitalizations, and overall improve the quality of life that we provide to our patients. So in short, this CEP model will alter and refocus physician incentives to break down barriers that might exist for this vulnerable patient population, ultimately increasing care quality while reducing those expenditures. So according to the findings of the PRT, as we've discussed this morning, the RPA has met or nearly met 9 out of the 10 secretaries' criteria for an alternative payment model. And so I want to discuss some of those quite quickly. Regarding the payment methodology criterion, the PRT has mentioned this morning, and with its notes back to us, that they had some concerns regarding payment of the preemptive and early renal transplant. And while the RPA remains committed to renal transplant as the gold standard treatment for appropriate patients, we do understand the PRT's critique of this portion of our payment model, and as such, we realize the need possibly to remove this reward payment for preemptive and early renal transplant. And then moving on to the criterion number 7, integration and care coordination. We look forward to discussing more this morning several techniques that we've identified that would incentivize nephrologists to serve as the principal care coordinator for this very vulnerable patient population and allow the necessary flexibility to address local clinical variables. We fully anticipate that a model that aligns incentives to keep patients healthy, involve them in care choice, and keep them out of the hospital will appropriately incentivize this care coordination and integration, both somewhat upstream, but also during these first 6 months of care during dialysis. And this is true for care coordination with other specialists and also with healthcare organizations. So specifically, the RPA anticipates that practices will implement any number of process improvements to achieve greater care coordination. These might include items such as systematic referral of all appropriate CKD stage 4 patients to kidney education, which is available throughout communities in the United States, formal coordination with vascular surgeons and interventionalists ahead of time or in the early period during dialysis, expedited office visits for ill ESRD patients so that they don't have to rely on the emergency room for care, and enhanced evaluation of post-hospitalization are all possible under this CEP model and do not require drastic infrastructure investments up front. We also look forward this morning to addressing all points raised by the PRT regarding the Secretary's criteria. As we've noted in our previous comments to the PTAC, the RPA evaluated several potential clinical payment models before refining our current episode of care model, which begins upon completion of CMS Form 2728. So acute kidney injury patients, even AKI patients, acute kidney injury patients who receive outpatient dialysis would not be included in this model because Forms 2728 indicates the diagnosis of end-stage renal disease. This model represents the RPA's effort to maximally impact cost, patient experience, shared decision-making, and high-quality clinical outcomes for nearly every subpopulation of patient transitioning onto dialysis, those with prior nephrology care, those with limited nephrology care, and those that we call crashers that had no prior nephrology care. And additionally, while not explicitly directing the management of upstream CKD care and patient education, we strongly anticipate that this type of care model will positively impact both upstream and downstream care. Regarding our proposal to initiate shared savings payment at a threshold of 30 quality points, the RPA believes that this was a starting point which represents care that meets or exceeds current standards. We have proposed some metrics based upon well-vetted clinical outcomes and others based upon patient experience and functional status, which, while evidence-based, remain to be fully normalized to this patient population, which ultimately is why we recommended a reporting metric for the first year so that we could ultimately normalize. We also note that some of the clinical outcomes we believe will have patient experience benefits, such as the clinical outcome of home dialysis, which provides patients that otherwise wouldn't be offered this modality an opportunity to dialyze at home rather than dialyzing in a center. And we believe that this amalgamation of outcomes represents really the greatest opportunity to provide new ESRD patients better care, fewer hospitalizations, and superior quality of life. And finally, the RPA wishes to recognize that there are other renal-focused alternative payment models that either have been proposed or are already in existence. There is likely not a single one-size-fits-all model for the heterogeneous states of early CKD, late CKD, incident end-stage renal disease, and prevalent end-stage renal disease. And this clinical episode payment model was designed to complement other efforts where appropriate, but also stand alone by serving all practice sizes, geographies, and patient populations. So again, on behalf of my colleagues within the Renal Physicians Association, I wish to convey my gratitude for the opportunity to work with this committee to refine this proposal. The RPA is highly committed to providing physicians the best possible opportunities to deliver world-class care and service to our kidney patients. We are also committed to engaging with and equipping physicians with tools and resources needed to deliver optimal care that our patients and really our communities deserve. Thank you all very much.
U.S. Department of Health and Human Services, produced at taxpayer expense.